to be able to go in town, like healthcare.
Also finance.
Yes, finances.
Mhm.
Good. And what do we know about rural communities?
It's usually a small community.
Hmm.
What do we know about small communities?
They might not have access to healthcare.
Think about it. If you live in a small community, if you live in a big city, are you going to know everything about everybody around you?
No.
That's the perks if you do live in a big city.
Yeah, nobody really cares what's going on with you, right? So think about these rural communities, and do you think everybody knows everybody's business?
Yes.
So what is that going to cause?
Like probably shame. Is that where you're going? But like embarrassment.
Think about that. I'm gonna come back to you because somebody's asking for help, so I'm coming back. Hi there. By yourself.
Hey.
What's going on?
Yeah, I don't know. Charity disappeared. So I don't know. She said
did
she thinks.
disappear. Okay, I'm gonna put you in another group, okay?
Okay.
Let me see how I do this. Sorry about that.
You're fine. She said her computer was messing up.
All right, I'm gonna put you with one, okay?
Okay.
Oh no, I'll put
She's-
you with six because six only has two.
Due to that reason.
Okay, what are we doing here? Alvira, I can't have you in the car, my friend.
All right, I just wanted to get on and tell you that I just picked up my car getting fixed and was
Yeah,
getting
I
homesick.
can't, so I can't have you in a car.
Okay, gotcha.
So I'll let Dr. Brown know that.
Okay, thank you.
Okay, when you can join from a solid place, okay?
Yes, ma'am.
Okay.
Just gonna
All right.
email you. Just hop off. Got it.
Sandra and Steven, what are we thinking here?
I'm trying to think of a pro for Royal Nursing.
Okay.
There just seems to be a lot of cons, but
I feel like
So I'm
you'd have the same general, I want to say population. It's like I grew up in a farming area, so it was all farmers. For my specific area, it wasn't much homeless. I mean, there was, but not much.
maybe
But I'm sure that's
establishing
not a.
establishing relationships.
Steven, did you feel like there was relationships that were established in your community? Like
Oh,
you
yeah.
guys all knew who the doctor in town was, right?
Yeah, and our doctor was real good. Like, it's a small story, but it's connected. When I was little, I shook my fist at my mom. My doctor saw it and asked me, "What do you do?" Told him nothing. Long story short, he told me if he saw it again, he's gonna take a needle, stick it in my butt, and make it come out my nose. I don't feel
That
like you
must
could
have
say
been
that to
traumatic.
someone in the city. Oh,
That
that was a
sounds
running
dramatic.
joke in my family for a while. If I
I
brought it
would
to my mother,
imagine
I'm sure I
so.
can still hear it.
That's really funny. All right, so you know that community and that doctor knew your family, knew your mom, and said, "No, we're not going to have that." Right. So that is definitely a pro. In some situations like yours, that was not a pro, but that certainly is. You know, the relationships you develop are going to be really close. That can also be a con. Why do you think that is?
Well, my girlfriend said her doctor tells everyone else's business.
Oh, that's lovely. Nice violation of HIPAA there, but that's true. Everybody knows everybody's business. So think about the groups that are not going to report, like mental illness, like abuse, right? You're not going to have this reported in this community, right? Because everybody will know. So they're going to keep it really quiet, right?
Oh, I see a con. They're exposed to more diseases like tuberculosis, pneumonia, typhoid fever.
You're going to get more chronic illness for sure, not necessarily acute. I mean, you may TB if you're depending on where your living arrangements, but certainly
Right.
you're going to see more chronic. Why would you see more chronic illness?
they probably don't go to the doctor.
Yeah. It's not common sense, but good. Think that way. They're not getting screened like we are in the cities, right? And
Right.
not that people in the cities are either, so don't mistake me, but something to think about. You guys are doing good. I'm sorry you only have 2, but that's how our policy now works, so we got to deal with what we got, right?
It's fine.
So, but don't get crazy. Just you're on the right path. You guys are doing great. So, Stephen, I want you to think of what you've experienced, because you're firsthand there. And what you probably have experienced is probably what's in the book too, to be honest with you. Because it doesn't matter where you are, the rural communities tend to have certain trends. Okay. All right, I'm leaving you guys. I'll see you in a little bit.
Mhm.
Sides.
Okay.
Okay, how are we doing here? Our migrant workers.
Good.
Good.
What do you think you're gonna see with migrant workers?
Each migrant workers on reduce.
My
Respiratory illness so far.
yeah, respiratory illnesses, musculoskeletal injuries, infectious
Pesticide exposure.
diseases, pesticide exposure.
Yeah, I would take that hearing and vision disorders out. That's not something we're gonna emphasize.
Okay.
I know it's in the book, but I don't want to emphasize too much on that. The other 3 are exactly where you're going. Very good. You are going to have respiratory illness or pesticide exposure for sure, and musculoskeletal. Think about why you're going to have those.
A lot of bending, a lot of picking.
They're more physical jobs.
Their feet
Yeah,
long.
yeah. They're physical. They're bent over all the time.
Yeah.
With our pesticides, think about our prevention that we can do. Right. It's a big one.
Masks.
So could we do some education about proper biomechanics?
Yeah, you could. And you want to do that before they have the problems, right? That would be our primary. Because once we have our problems, what are some things we would do as secondary?
Train
Basically
them
treating,
for what they have.
screening.
Yeah, so we're gonna have them bend over. Do you have aches and pains in your right or left, right? Those kind of things. Right-sided pain, we always think of what?
Liver.
Down your leg.
Blood clot.
Hmm.
Sorry, I have a toddler back there.
Sorry, I couldn't hear.
She said
What was
blood
the
clot.
question?
Pain down one of your legs.
Oh, sciatic nerve
Mhm.
problems.
No, you're going to see that a lot among our migrant workers because they are always compromised and they're always using muscles that, in their back and lower back and there. So good. So those kind of things. So think about our prevention there for our pesticides and for our musculoskeletal. You guys are doing great.
I guess I had a question overall with for primary prevention. I know that it stated something in regards to reducing the exposure to the pesticide, but for migrant workers, I mean, that's not really something that they could potentially do.
Who would you teach that to as a primary prevention?
I would say more so who's ever running the farm.
Yeah, the farmers, right?
Yeah.
You teach them because the migrant workers, they really, they're not gonna have a lot of help, right, with
Yeah.
their stuff. So good thinking there. All right, keep going. I'll join you guys in a little bit. But you're doing
Okay.
good.
Thanks.
To police.
Put that in there.
Does that make sense to y'all? Like, as far as what that question is asking?
Yeah.
Yeah, I think that's very relevant. Put that in there.
Okay, making sure, because I
All right, we're doing a bunch in this group, so we have some different things. You guys are Medicaid and Medicare, right?
Yep.
Yes.
And then homeless. So we pull in our vulnerable population here because that's a big, big thing. What do you think about the homeless and medical care?
They don't have access to,
Yeah.
Where are they gonna get their services?
they usually go to free clinic.
They go somewhere else. Does
The
anybody
hospital.
work? Yeah, where do they go in the hospital? You're right, Mary.
Yeah, the hospital.
The ER. They go to the ER because they don't know anywhere else to go. You're lucky if they know about the free clinics, right? And
Yeah.
hopefully they know about them. And that would be nice if as community nurses, we promoted that more among, right? But you're gonna see them in the ER and they go to the ER, but by the time they get to the ER, they're pretty, significant shape, right? They're have ulcers on their feet, they haven't eaten, they're freezing, right? If anybody works in an ER, which I guess you three don't, but what you'll see is when
I
you start-
have, I used to.
yeah. So think about the
Mhm.
weather. Like, where are you, Shanice? I forget.
I'm in Virginia.
Well, Virginia. So you get cold weather. And in that cold weather, it would be oftentimes that's who you have in the ER because they need shelter and they want warmth, right? So think about what does that do to our medical system? What's that do to the nurses in the ER?
Well, it puts a lot of toll on them because you have to treat the individuals regardless whether they have funding source or not.
Yeah, you do. And the thing about that is that think about quantity there. If you have 5 homeless people coming in because it's cold out, and you have 5 people with, say, a kidney, a respiratory, an abdominal, and 2 chest pains, that's really gonna prioritize what we have to see and who we have to treat. And so think about what that does to the medical system as a whole, financially and from a staffing perspective, of course. Medicare and Medicaid, I want you guys to know the difference. What's Medicaid? It has the word aid in it.
And it's up there. Thank you.
Does it have to do something with age?
No, it has something to do with aid. Who needs aid?
Families, disabled,
Disabled, who
the
else?
poor.
That's right. So it has the word aid in it. So we're going to be giving aid to what kind of people?
People who are low income,
Mm-hmm.
can afford insurance.
Mhm.
Yeah.
And then we have our Medicare, and it has the word care in it. And what I want you to think about is what population do we know is going to need care the older they get?
The elderly.
Elderly, and
Over
especially dementia.
65.
Yeah.
Yeah, over 65. So this insurance helps care for the group that needs care as they get older. And so we also want to make sure we know who's federally funded and who's state and federal. That's a big
So
difference.
the Medicaid is state and federal, and Medicare is federal.
Mm-mm.
It's the opposite.
That's what our book
So
says.
Medicaid, what you remember about Medicaid is it's called something different in every state. That's how you know the state's involved. So like in Colorado, it's called CHP for kids. What's it called in Vermont, Shanice?
Well, I'm in Virginia.
In Virginia, sorry. Whatever. I knew it was a V.
That's
Go
okay.
ahead. What is it called there?
We just call ours Medicaid services.
It's called something. Gould, do you know what yours is called? For kids?
TennCare, right?
TennCare, yeah, TennCare.
For
Yeah.
Nashville, well, for Tennessee, it's called
Yeah.
TennCare.
Yeah. See, so they will have their own names. That's how I like to remember the difference there is that and if you go Medicare, it doesn't matter what state you're in, it's all Medicare, right?
Mhm.
Thing to remember about Medicare is that we'll cover some services and we have to be sensitive to our older population because it may not cover all the services. They try to be pretty good, Medicare, but we also would teach to our elderly population when they're in their 40s. What do you think we're going to teach them? Before they're Medicare eligible, what are we going to teach them about? Because
I'm
once they're
honest.
retired, they're
more
not
specific?
working. So they're not going to have insurance to work. So what kind of insurance might they need to look for?
Medicaid?
So it depends on their diagnosis, and sometimes they can go from Medicare to Medicaid. But what you're going to teach them about is our alternate or our secondary insurances, right? Because they can sometimes buy into them, and so that they have them when they retire on Medicare.
Are
Okay.
you talking about like Part A, Part B, Part C?
No, so
Professor
that's
Lyon?
Medicare parts.
Okay.
So that would be like if you have Medicare, then you will pay an additional $500 a month. I just know this from my in-laws for the $500 part. So they pay $500 a month to have supplementary insurance so that if Medicare does not cover something, they are not held liable for it. So
Okay.
it'll sometimes be through Aetna, sometimes through Blue Cross Blue Shield. There'll be a private agency that's you can supplement your insurance.
Okay.
Okay.
The book didn't lie to me because
It
I
didn't lie
looked
to
in the
you.
appendix, the glossary told me that Medicaid was jointly sponsored by the state and federal program.
Okay, so it is jointly funded, but it's
Okay.
run by the state.
Okay,
So it
okay,
gets money. Both of them are federally funded. They get money. But
okay.
who runs Medicaid is the state.
State, yes,
Does
okay.
that make sense?
Yes, it does.
Okay.
I have
So
a question. So with
Uh-huh.
Medicare, that it's funded by the taxpayers and the Social Security Administration. How true is that as far as like, because I thought like this, like us taxpayers pay both Medicaid and Medicare.
Well, so us as taxpayers, what we pay into is we pay into Social Security. And the
Mhm.
goal for Social Security is to actually pay our elderly people when they get the time for that, right? And so
Okay.
then Medicare is under a whole different wing. And so if
Right.
you ever look on a paycheck, sometimes you will contribute to something depending on your agency, and sometimes you won't. But no, Social Security is really solely for things like disabled, because disabled can get Social Security, right? And elderly can get Social Security.
Okay, thank you.
Right, yeah. All right, you guys are doing well. I'll leave you and go to another room, but
Thank
we'll
you
come
for
together
popping
in a few
in.
minutes.
Yep.
Oh, sure. All right, let's see here. 6, yeah.
Meds. Sometimes they even provide their like diapers and whatever personal care that they need.
Yeah,
What
hospice is the
we
only
buy?
Medicare benefit that includes medication, medical equipment,
Right.
24 hours, 7-day a week access to care and support.
Yep.
What slide are you guys doing?
7.
All right, so what are we thinking about when we think about the differences?
So home health nurses work with chronic illness and all that, and hospice is the end of life care.
Okay, what else can you tell me?
So like we were saying, like the home health nurses like promote health. So like they help with like medication education, they help with like disease management education, diet education, all that, whereas like hospice is more like comfort care. There is no like promoting their well-being. It's pretty much there strictly for comfort.
Mm,
And
okay, what do we deal with hospice that we deal with home health care as well? What group of people are we dealing with?
Your vulnerable populations. Or are we talking about well, home health care is not always vulnerable populations.
No, it's not. You
Yeah.
are correct. What group are we going to be working with though, and who are we going to be teaching to in both of these?
Caregivers, their families.
Good. So that's a similarity. What else do we know about home health care and hospice? What are some things that we will do together on both of them?
quality of care.
Always quality of care. What's another thing that we always do as nurses that sometimes we don't think about? It starts with a C, but particularly with home health nursing and with hospice, we have to do this. It's called collaboration, right? Interprofessional collaboration, because as nurses in the home, we cannot work alone, right?
No, we always have
need
to
to-
call the physician for everything. I do home
Sure.
health care. So.
Oh, so you're a good one. You know exactly. So that's the good thing. When you do something, you practice it. You always have to call the doctor. And aren't you out there? And whether hospice needs a doctor or hospice needs physical therapy or home health needs any of those, right?
Yeah.
You got to
still
get
have
that
to call the
collaboration going because it's all on you.
Mm-hmm.
Right? So think about that collaboration and how we would, as community nurses, how are we going to make sure we include everybody, right? What also is on us is a liability. Why is liability on us for hospice and home health?
Just providing that care by yourself.
Right, we don't have anybody who's watching
Yeah.
except the family.
Mhm.
And a family that's going through something with home health or hospice, they probably have a lot going on in that family, don't you think?
Sometimes.
So sometimes, true,
Yeah.
sometimes not. And if they have a lot going on, are they going to necessarily say this nurse is doing exactly what she should be doing?
No, everything you do is going to be wrong.
Exactly. So something to think about, and that's a liability on us. So we really have to follow our practice acts really closely, but very good. What else did I ask you on this slide about hospice and home health? Hold on, let me look.
How are they different?
Yeah, how are they different? So you guys talked a little bit about time and how they're different. What else do we know?
We know that with hospice, you have to have, it's like 6 months or less, and then they reevaluate you, and either you can continue depending on, like if you're getting better or worse, you might can continue the program, or sometimes they might switch you from hospice to home health.
Okay.
Or to palliative care.
Mm-hmm. And can't they also do the same for home health, though?
Yeah.
If you're getting home health services, they can say, okay, you're good, right? You don't need
And
it
we could
anymore?
also in home health be like, well, there's nothing else we can do. Like we suggest maybe hospice step in.
Good. Yeah.
So
We have one home care nurse and one hospice care nurse in this group. So
you guys are really knowledgeable. See, it was a great group to be in. Who does hospice care?
I've done hospice care and home health.
Wow. That's pretty impressive. I admire you for doing it. I think that's a really difficult field. What is it that you have to be so sensitive to?
You have to be sensitive to the family's needs as well as the patient's needs, because sometimes the family depends on you. Like they come to you for everything, like, what should I do? What should I do? And you have to put your biases aside and just give them the pertinent information of, okay, this is what it is, and these are your options. You can't say, well, if it were me, you just got to give them the information as it is.
Good. And that's I'm glad you spoke about that, because your biases here again, we'll talk about that again. It'll come up in every type of nursing that we do, but you got to be careful, because what do you have to be pretty comfortable with in order to work in hospice?
Death.
And some people
I-
are not.
No.
So I would say that so when I worked in long-term care, obviously I worked alongside like hospice nurses. They would come into our facility and like take care of our patients. And just from what I've seen, I feel like the families in hospice care, which I'm not going to say all, because I guarantee it's not always all,
Sure.
are just like beyond grateful for the care that like the hospice nurses are giving them and just like being there for them. Whereas like on the flip side with like home care, we talked about like sometimes no matter what you do, your families are never happy. They're never going to be happy. And it's kind of like two sides of it.
Sure.
Like
And
with hospice care, they
yeah.
kind of know what they're signing up for.
Mhm.
They're well educated on what could happen and what's possibly going to happen. So they're a little bit more open to.
Sure. And think about that family crisis that we talked about when we did families, about how crisis is for some, what might be a crisis for some may not be a crisis for others.
Yeah.
So what you're going into, you really never know. In home health,
Yeah.
if it's a, relatively healthy person who something traumatic happened, that's going to be family crisis for that family too, right?
Yeah.
So good. Very good. Okay, you guys are doing good. We're going to come back together in about a second. I just
Okay.
want to make sure I touched in with everybody. Just looking at my rooms here. It's 1, 2, yep, 3, 4, and yeah, okay. I'm gonna close all rooms. We're gonna come back together, okay, and go over our topics as a group, okay?
Good job, guys.
Thanks, ladies.
Good work. All right, so in your paper, I actually printed it out. I will pull it up for you, but my first concern is with your lice. Your signs and symptoms, it was not on the site that you cited, so I don't know where you got that from. Hold on, let me bring. And
I
will
got
show-
it from my med surge book, which
Okay,
should be
but you didn't cite the med surge book. So I had no idea where you got it from. The other thing I'm going to tell you is the writing in there is not nursing school writing. Can you tell me what secondary excoriation is, especially parallel linear excoriations in intrascapular region?
Wait, what was that? I'm sorry. I couldn't
Right,
hear you.
exactly. There's no way that that's your writing. So I don't know because I don't have your med surge book and I didn't see it on your sample. I'm pulling up your paper. Hold on one second. So what I was pretty clear about, and maybe I was not clear enough about, was that I do not expect cutting and pasting from anywhere. And I can tell you right now that this is not your writing in the sense that, hold on, I'm pulling your paper up right now.
All right. Well, I definitely did not copy and paste from anywhere. I could look up right now, lice.
So
and
I
then-
want you to tell me right here. Okay, are you telling me that this is your words?
The first three are, and then this was.
Tell me what this word means right here.
Pruritus is itchy.
Okay, and you would write that in a paper?
If it was for nursing school, yeah.
Okay, how about this one? This is what I was asking about that you said what?
Excoriations or like rashes, so secondary excoriation, especially parallel linear excoriations in intrascapular regions. So rashes, I mean, in the head with the lice. I mean, I got it from right there. That first one is the med surgical nursing assessment and management of clinical problems. Is the
Okay, so
first.
I want to see a copy of that page that you took it from then, because I don't have access to this book. What I'll tell you is on this one, I can cut and paste and show you on CDC.
That I got more so for like the teachings.
But I want to
But the-
pull up that website and show you what that website says that tells me that this is not in your own words. What I'm going to tell you is this, is that we can go back and forth on every word on this paper if you want. I'm not going to. What I'm willing to do with you at this point is to give you another opportunity to rewrite this paper in your own words. What that means is that you do not cut and paste off of any website. And if you are saying it's all in your own words and that's how you write, I'm not going to deny that that's the case. What I'm going to ask you to do is relook at the paper, redo the paper, and make sure that you're submitting it the way that you would want it graded, so that if I showed it to Dr. Brown and we went through all these websites, what I will tell you on your education is that I have it printed out here. One of them is right off your site. So let me see which one it was. So what I'm going to do is give you the opportunity to go back and redo the paper in your own words if you want credit for it, because I'm not going to give credit for something that I don't believe was written by a nursing student.
Okay. And then do you still want me to or take a picture of my book?
I do, because I do, because I want to see the way it's written and the way it's presented. Because I mean, I'm just surprised that that kind of language is being used. But if that's not what the book says, that, I mean, if the book uses different wording, I just tend to think I read these papers all the time. So like, I know how students write, and that to me just was a big red flag. But if you're telling me that that's the case, I'm going to pull up though our lice, the CDC site, and we're going to look at that together then.
Okay.
There's that, and let's see, where's your education? Where are we at lice? Let me go up to lice. Okay, I want you to look right now, Abigail. Avoid head-to-head contact during play and other activities at home. Look at your paper. Oops. Avoid hair-to-hair contact during play and activities. That's right off the website. Correct?
Correct.
Okay. Do not share any clothing. I don't know if that's one of them, but do not share clothing right there. Second bullet point, right off the website. Your paper says it word for word. Do not share any clothing. Right?
I mean, I thought that was the whole point of like citing them, is like obviously not
so-
copy and paste, but also understanding that. I mean, I just feel like this information, I guess, is like very self-explanatory. So like writing it in my own words, I mean, I feel like it's still going to kind of sound like I got it from this website.
Yeah, but you're not going to use word for word like I just showed you 3 of the examples, right?
Yeah.
What are some other ways you could say that? Well, what's another way that you could say whatever it was? Because right here, avoid hair-to-hair contact during play and other activities. On your paper, you say, avoid hair-to-hair contact during play and activities. What maybe you might say so that you wrote it and so that the CDC didn't write it.
Make sure to not, I guess, avoid contact or avoid hair contact with other children while playing.
Okay, what is the key here? Avoid hair-to-hair contact during playing activities. What are you trying to say?
Basically, just avoid contact with the infected child's hair while
Right.
doing any type of activities.
Doesn't matter when, right? Does it really matter? No. So you could say, do not touch hair-to-hair with another patient, another kid. Or do you understand what I'm saying?
Yeah, I get what
Do
you're
not share
saying.
any clothing, especially those that go on or around the head. So how's another way we could say that?
Do not share any clothing.
Yeah, don't share clothing. Don't share brushes or towels. This one right here, I can tell you, disinfect these items that have been used by the infested child in hot water of at least 130 degrees for 10 to 15 minutes. I know that you didn't create that, right? You didn't come up with the temperature. That had to come from
No, I
somewhere.
got that from the site.
Yeah, right. So you want to just be really careful with this. And the signs and symptoms, I'd be hard pressed to believe that this is coming out of the book, but as is this that we just looked at. So what I'm asking you to do is put it in your own words so that I know you understand what you're writing about.
Okay, and then do you want me, I mean, I have it right here in this book right now, open, but I don't know if you
Yeah,
want me
just
to-
take a picture right now and send it to my phone.
Okay,
I'll give you the phone number and we can look at it together.
okay. What's your phone number?
732-857.
Sorry, can you
71
repeat that again?
Yeah, sure. 732
732
857
857
7188.
7188.
Yeah. But do you see how on your teaching points they're pretty much right off the website? Do you understand
Yeah.
how that is? Okay.
Yeah, I guess like I mean I definitely didn't like copy and just like paste it on there.
No, and if you did copy and paste it, I wouldn't be game for a new one. You know what I mean? But
Yeah.
I just want you to well, so what you just sent me though doesn't have signs and symptoms. It has
It's the
etiology and
clinical
pathology, clinical menace. Oh, here. Yep. So I want you to look at your 2 points right there. Red something, what does it say?
minute, red, non-inflammatory, points flush with
Yeah,
skin.
nits and eggs are firmly attached to hair shaft in head and body. That's word for word under your signs and symptoms. Look up here.
Yeah.
That's your first bullet point. Your second bullet point is the one above that, right? Word
Yeah.
for word out of the book. Right? So if you're doing word for word, something like that, which you really don't want to do, try really hard not to do that. But if you were going to do that, the way you would give credit where credit's due is you need to put that in quotation marks, the entire thing.
Okay.
Got it? So,
Mhm.
and so it's just pretty clear to me. That's why I said to you, that can't be your wording. I mean, you know what I mean? And it's right out of the textbook, which is fine. They're using your textbook as a reference. That's really great, but you got to interpret the information and then spit it out. Does that make sense?
Okay.
All right, so I'll give you till next Tuesday. You're gonna get 10% off on it. I'll tell you that because I couldn't grade it when it was due. But other than that, you know, if you have any
Okay.
questions while you're doing it, let me know. And we
Well,
can
I
go over it.
appreciate the opportunity to redo it. I definitely wasn't trying to cut and paste or cheat in any way, shape, or form,
No,
but
I know, and
do-
so I do think also this class has the tendency to I don't know how to say this. I think sometimes you guys haven't had the experience of rewording stuff, and I think that's difficult, but that's really important for you guys as you move forward in nursing. So that's the only reason I ask that you guys are being really careful about it.
Okay, thank you.
Okay, alrighty, so by next Tuesday you can get it to me.
Okay, thanks.
All right, take care.
Okay, you too.
Okay, bye.